Hi everybody, Dr. Jager here. I just washed my hands with the alcohol on the wall, just as you should do before any physical exam, before touching your patient. This is Alvar. He's our simulated patient today, so he's going to help us out. As with any physical exam, my exam starts as soon as I enter the room and start interacting with the patient. So I'm already taking note of how Alvar looks sitting here. Does he look happy? Does he look sad? Is he slunched over, looking depressed or uninterested? Or is he, seem like he's, having a good day and he's interacting appropriately with me? And that's going to continue throughout my exam. Does he follow my commands? How does he move when I ask him to move? All the way throughout. And so I'm judging that part of the exam all the way through. Today we are going to focus on what we're calling the core exam, which is your basic exam that you're going to learn from here in the beginning and then build upon throughout the rest of this year. It is a basic, generalized head-to-toe exam, which is sometimes called a screening exam, as we will touch over a little bit of the exam in multiple parts of the body. And the point being is that if we find something abnormal, that should prompt us to delve deeper, to do a more detailed exam on that part of the body. So for instance, if I was listening to Alvar's heart and noticed that he has a murmur or another abnormal heart sound, then that should prompt me to do a much more detailed cardiovascular exam. Or if I find that he has a difference in reflexes from the left and the right, that should prompt me to do a more detailed neurologic exam. And so that's one reason why this is sometimes called a screening exam, but this is going to be the exam we want you to use on every single patient you see, and then maybe forever, depending on what profession you choose to go into. So the exam starts with the vital signs. As I mentioned, we're already looking at kind of him from a general standpoint and also from a psychiatric standpoint, how his mood and affect, speech and language would be during our normal interactions. We're going to move down basically from the head down to the feet, and starting with some head, eyes, nose, throat. We'll look at his neck and lymph nodes. We'll move down to the chest area where we'll do lungs, then get into the cardiovascular system, get into the abdomen, and then do neuromuscular at the end. So I'm going to start with the vital signs, and normally your patient, before taking blood pressure, hopefully will be sitting in the room quietly for at least 5 minutes before doing that. So I'm going to start off with taking his pulse. This is usually done just feeling the radial artery here, and if you just look at hopefully there's a clock on the wall, and you're going to wait 15 seconds until you've counted out how many beats he's had, and then multiply by 4. Then you're pretending to still listen to the pulse, but actually then you're going to start to pay attention to how many times he's breathing. So either you can watch his chest rise and fall now and count the number of breaths again in 15 seconds and then multiply by 4, or you can keep your hand on the back and just, again, you're still this whole time pretending you're listening, feeling the pulse, while you're actually listening or watching him breathe to get that part of the breath. Because as you know, if you ask somebody to breathe, they're going to change the way that they're breathing, right? So those are the first two parts of that. The other things in terms of the height and weight, we're going to go over that in class. And then, of course, the temperature, we'll also go over that part in class. The most important technique that I want you to learn well, though, is taking the blood pressure. This is a difficult skill that takes a lot of practice, and there's a certain way that we want you to do this that'll make it be most accurate. So the first part of this is making sure that you have the right size cuff. So I'm going to open this up. This is an adult large cup. You can see with this, usually there's a a bladder marking. So 80% of this bladder marking should be able to go at least around his arm, which easily it does. And then this should go at least halfway down his arm. If not, then you need a bigger cuff, but this is really important. If the cuff is too big, it's going to underestimate the blood pressure. If it's too small, it's going to overestimate the blood pressure. So the brachial artery is located on the medial side of the antecubital fossa here, which I can easily feel. Not on the middle or not on the lateral. Make sure you know where it is, because that's really where you're going to be listening with your stethoscope. And that's where this nice artery indicator goes. So we're going to stick this here. Make sure it gets adequately tight there. The monitor is over there on the wall. So the technique, and you can just relax still, that we want you to learn is actually have the patient start here. Now I can either continue to feel his brachial pulse or move to his radial pulse. And I'm going to pump this up until I don't feel his pulse anymore. And so I'm just going to start going up, and I know that probably around 120 it's about gone. And so from here I can just leave it. Now I'm going to just go up. I don't feel his pulse anymore. I'm going to go up 20 more points, 20, 30 more points, and then stop. That's when you can put your stethoscope on, put your over that artery. Now the caveat here is that his arm needs to be at the level of his heart. It needs to be relaxed. And notice that I'm holding it, and the arm should be straight. If the arm is bent, or if he's holding his arm up, then it's going to alter the pressure. So from here, I'm just going to gradually open this up slowly, going down 2 to 3 beats every second. I hear the first beat really loud and clearly, and I keep going down slowly until that beat goes away, and then I have the lower number. So here's about 120 over 770, perfect. Then I would repeat it on the other side to make sure that I have it right. So that's how we want you to do the blood pressure, to make sure you get the correct reading. And so, as I mentioned before, we're going to continue the core exam. We're basically going to start from the head and move our way down. Again, the whole time I'm looking at his skin, whatever part of the body I'm looking at, and I'm also would be normally judging our interaction as well throughout this time. So starting with his face, I'm just going to be looking for symmetry, especially forehead, eyes, mouth, and his cheeks. And this would be to see, kind of is a cranial nerve check in a sense, mostly facial wise, but to see, does he have a droop? Does something look off? Does he have a droopy eyelid up there suggesting a ptosis? Anything that might suggest that I need to do a more detailed neurologic exam. From there, I'm just going to look at his pupils. He has darker eyes, so it's a little bit harder to see, but I'm going to want to just make sure each pupil looks the same size, which they do. And then I'm going to take out a light, and I'm going to check both his direct response and his consensual response. So first, I'm looking in this eye to see how this eye reacts and see that it quickly responds. And now when I shine my light on this side, I'm looking in this eye to see that this eye constricts and then relaxes like it should. Then I'm switching sides. Now I'm looking for this eye to react directly, and now I'm looking in that eye to see if it responds and constricts when I'm shining the light on the opposite eye. And both of those do as they should. From there, I'm going to continue to work my way down, now getting into his mouth, and quickly, preferably using a tongue depressor just to make sure you can get where you need to. Again, usually having a light source, unless you have a really bright room, open up for me. So I can look around. I'm just taking a quick look at his dentition. Going to push down, have him say, ah. Ah. Excellent. Lift up your tongue for me. And so I'm getting a quick look to make sure I don't see anything abnormal. Again, I'm assessing actually some of the cranial nerves kind of in the process there. And again, he's following my commands, and I'm not finding anything abnormal, so I can continue to work my way down the exam from there. Now I'm going to move down to his neck. So I'm going to start by looking for symmetry, both anteriorly. I don't see, everything looks nice and smooth. I don't notice any lumps. His skin looks completely normal. And then I'm going to I like to take a look from the side also. So from a thyroid exam standpoint, the neck should dip in when you get below the thyroid cartilage. If I would be looking from the side and seeing that his neck actually bulges out here or actually goes straight down and doesn't go in, that might be suggestive of thyroid enlargement, and then I would need to look into that more closely. That all looks good and appropriate. So I'm going to feel for lymph nodes. Next, my finger pads are going to start at the back of his occiput and just kind of smoothly move forward, feeling behind his ear and in front of his ear. From there, I'm going to move forward to the tonsillar and the submandibular, submental, where those nodes would be. I don't feel any abnormalities. As I'm going down, I go behind his sternocleidomastoid muscle, push it forward just slightly, and now I can go down the posterior cervical chain, go in front of the sternocleidomastoid. Now I'm going down the anterior cervical chain, and I can keep working that way down if I want to go to the supraclavicular nodes. Notice that when I did that, I didn't take my hands off and feel like this, and I went more of a sliding motion, because if I take my hands off and go like this, I might actually miss the lymph node if it was slightly enlarged or abnormal there. And all of that is completely normal so far, so I can continue to work my way down into the chest exam. So if this was a female patient, this was where you would need to start thinking about keeping them covered appropriately during the exam. Whenever you're doing any part of the exam, you want to be looking directly at the skin as much as possible. Excuse me. So with him, we don't need to be concerned with that, but we still always want to take in consideration and ask if it's okay if we remove the gown, if they're comfortable with that, to always respect your patient along those lines, so they'll be comfortable. Always tell them what you're going to do before you do it, so that way they won't be wondering what you're doing when you start to feeling a part of the body that they may be uncomfortable with. So if it's okay with you, we'll go ahead and take your gown off. I'll just untie it here for you. All right. Thank you, sir. So now I can start with moving down into the chest exam. I'm starting off with looking just at symmetry. Is his posture abnormal? Does he have a barrel chest? Does he have a pigeon's chest? Something like that, and he looks very symmetric. The next thing I'm going to do is I'm going to check for respiratory excursion or chest expansion by placing my hands on his chest and then having him take a deep breath in and out. When you do this anteriorly, you want your thumbs to be right here at this angle, because when he takes a deep breath in, notice how my thumbs move out, and his chest, I can easily see, is expanding the way it should. A patient with hyperinflated lungs like COPD, paradoxically, your thumbs may actually move inward, which really strongly supports that they're hyperinflated with COPD. I'm going to repeat the same thing from behind, putting my thumbs about at the level of his scapula. Again, taking a deep breath in, my fingers and hands move out and all the way out. So again, I'm watching that expansion in and out. The reason why this is so important is I can make the diagnosis of pneumonia when a patient comes in just with a cough and a fever, and if one side of their chest doesn't expand, I can make the diagnosis of pneumonia right there without even having listened to them yet. So simple, very easy technique. So after we've done our chest expansion, we're going to move on to percussion. Percussion does take a little practice for sure. You got to let your wrists relax. If you're very stiff, it's not going to work very well. We're trying to hear, obviously the lungs are air-filled, so it should be resonant. It should have a slight boom to it, as opposed to if I percuss on his thigh like this, you can barely hear it. The noise is very, very brief. And so whereas up here, you can hear some noise to that. If you're really struggling with it and you don't have, you know, a concept of what you're looking for, you could take your hammer out and hear what it sounds like, and then try to practice that until you can get your hands to do if you don't have a hammer. But with percussion, with anything on the lung exam, I'm comparing one side to the other. Obviously over here where the heart is, there's not a bunch of air, so it's not going to be resonant, but everywhere else should be resonant. And so I'm going to start at the top and compare sides and work my way down systematically here. The other thing I should mention is that the part of your finger actually striking is actually this joint, not the tip of your finger. So I'm trying to press this down into that joint. And then again, the tip of my finger is the one tapping. If you try to use your pads, that won't work either. So get that firmly on there, get your fingertips, and that's where your tapping will come from. And work your way down. Some people, depending on if you're trying to work something out, they use this when they're trying to measure things. But for this aspect, we're comparing one side to the next, and again, working our way down. Now over here, it should be very dull. There's no resonance. Working way side to side. Then I'm going to move over to the back. Repeating the same thing. Press firmly, let that wrist swing. And then you're done with the percussion part. The last part of the lung exam, so you see there's a lot to the lung exam besides listening. A lot of those parts are left out. The last part is listening. And again, I'm going to be very systematic in working my way down, both front and back, as we do this. So press your stethoscope firmly. You're going to ask your patient to breathe in and out of their mouth. Quietly, if they make noises, you know, that kind of stuff. Or if they breathe in and out of your nose, you may get whistling noises, and that'll mask what you're actually trying to hear with the lungs. So sometimes it takes a little instruction. Let them know that the stethoscope may be cold. If they start to feel lightheaded, they should let you know. So go ahead and deep breath in and out of your mouth for me. This is the only place that you can hear the right middle lobe. So if you neglect to listen to this part of the lungs on your exam and you only listen to the back, for instance, you may miss the findings that are there in that right middle lobe. So very important to focus on that specifically. Moving to the back, deep breath for me. And that'll complete the lung part of the exam. Again, if you find an abnormal finding, you would need to do some other techniques to help try to figure out what that sound was. So we finished the lung exam, and now we're going to move on to the cardiovascular exam. So I'm going to start by just doing some general things while he's seated, and then before listening to the heart. So we're going to start kind of peripherally, and then we'll listen to his heart specifically. Often part of a cardiovascular exam, you're going to look at the nails, look for clubbing, look to see if they're good and perfused, which both sides look normal, and get a look at the hands. From there, I'm going to feel both radial pulses at the same time. You can relax your arms. And I'm wanting to make sure that they actually feel the same. side by side. So the timing should be the same, the amplitude of the impulse should be the same, and to make sure, you know, if there was a difference in one arm, I would be able to notice that. Without doing simultaneously, I may not notice that, and then I could miss that he has some type of stenosis or something like that in that side. I'm going to do the same thing now, moving down to his ankles, and I use my whole hand to start off by trying to feel the dorsalis pedis pulse, because it's a little bit different from everybody, and then I can focus in on it. Again, I'm feeling simultaneously the amplitude, the timing. I sneak my fingers back here to posterior tibial arteries. And then the last step that I would do, certainly when I was doing a full, more detailed cardiovascular exam, is compare the upper to lower. There'll be a slight difference in the timing, because obviously takes a little longer to get down to the feet, but the amplitude should be the same and the timing should be just a fraction different. Like if I felt this and there was a significant delay down in his feet, that might tell me that he's got some type of blockage along the way that I need to pay more attention to and again do a more detailed exam. So after doing a basic peripheral exam, I'm going to move on to his heart. And again, I just make it a habit always to look at people's neck and look for their external jugular veins and see if I can even see their internal jugular vein pulsations as part of my routine. So get into the habit of just looking there as I'm starting to look at the chest as well. Again, if this was a female, you would need to specifically ask her and to tell her what you're going to do before you're doing it. I always like to listen to them seated, since they're already here, before lying them down. Just heart sounds, whether they're the usual heart sounds or murmurs, will sound different whether the patient is seated versus lying down. So I'm going to start off, and all of this will be with the diaphragm of your stethoscope, or firm pressure if you have a tunable diaphragm, and I'll talk about that in just a minute. But we're going to hit the 4 main areas, or 5 if you think about it, and then I'll have him lie down after that and do the same thing. And he can just relax. You have to take the time to listen for each heart sound, the first one and the second one, to make sure you know which is which. If you're not sure, you feel a pulse at the same time to know what S1 is and S2 is. All right, so I don't hear any abnormal sounds there, so now I can have him lie down and we'll continue the exam with him lying down. So we now have our patient lying down, and so we'll start by trying to actually visualize the point of maximal impulse, or the PMI, of his heart. And looking at his chest here, I can't see a specific spot. I can see his chest moving. If you want to try to figure out the timing, you can try to look at the carotid upstroke here, or feel his pulse again to try to see when you're trying to see. Otherwise, you put your whole hand down there, using the palm of your hand to feel this. My thumb is actually kind of extending up the side of the sternum there, and I'm feeling here for right-sided impulses, which would be abnormal, and feeling here for where his left heart should be hitting the wall. And once I find that spot, I can then take my fingers and move it in there and feel exactly what size it is. And his is subtle, but it's right here, and it's about the size of my finger, maybe dime sized, which is the appropriate size, and it's just a slight little tap there. So the reason why that's important is that when I'm listening for low-pitched heart sounds, S3s and S4s, this is where I need to be listening for that, or even just medial to that with my bell when I do that. So that gives me an idea of where that is. If the PMI is located over here or farther out, that tells me his heart's likely enlarged or his left ventricle's likely enlarged, and that would be considered abnormal. Again, if I felt impulses here or impulses even down here, that would tell me his whole heart's enlarged, or maybe the right side has dysfunction as well. And so feeling the heart definitely is helpful for certain things, but knowing where you need to listen really is really helpful. That should be normally, classically, it's in mid-clavicular line in the 5th intercostal space. And so if I try to count down his ribs, 1, 2, 3, 4, here's 5th. So he's right there, right where he should be in the 5th intercostal space in the mid-clavicular line. From there, I continue and I can go back and listen again to his heart sounds. Again, you have to take the time to focus in, knowing when S1 is, knowing when S2 is, listening to each of those sounds, making sure they're appropriate. Listen to the interval between S1 and S2 to listen for murmurs. Listen to the interval between S2 and S1, so in diastole, to listen for murmurs. And then you can move on to your next spot. This is all done with the diaphragm. This is a tunable one, so it has both high-pitched and low-pitched. So when I just put the bell, this functions as a bell when I just place it lightly and seal it, but when I press down, it turns it into a diaphragm for high-pitched. If you have a stethoscope like this, another excellent stethoscope, obviously you have the bell and the diaphragm on opposite sides, so you just have to switch it when it's appropriate. You always listen with the diaphragm in every spot and listen with the bell down here at the apex near the PMI for the low-pitched sounds of the S3s and S4s, and also for the low diastolic murmurs. So I'll go ahead and do that now. I can see his carotid impulse here, so I can easily tell when systole is. S2 should be loudest up at the top. It's appropriate. And as I'm moving down the left sternum just a little bit, I want to try to see if I can hear splitting of the second heart sound. Which I can actually hear on him. When he took his breath in, it's just a normal breath in. You don't have them accentuate the respirations, it's just normal breathing. So that's one of the things I'm looking for, and I continue to work my way down into a tricuspid area. And then over the apex. Here I'm going to be listening with the bells, specifically for the low-pitched sounds. So I'm just barely putting any pressure, I'm just sealing this. And to further accentuate that, you can have them turn just a little bit onto their side. Just right to there, that's perfect. And again, just slightly listening with your bell. Excellent, thank you. That's where you, if you're going to hear an S3 or S4, putting your patient in lateral decubitus, or certainly a diastolic murmur, they'll likely need to be in lateral decubitus for you to even be able to hear it at all, because they're so soft. So after we've listened to his heart, while we have him here, let's talk quickly about assessing for edema. This I would have done with him in a seated position, but we couldn't show that very clearly. So when you're looking again at the lower extremities for the peripheral exam and you're checking for edema, you want to take your thumb and put it over a bone, and if there's edema there, you let your finger sink all the way in there until it gets down to the bone, however long that takes, and then when you remove it, you'll be able to see that indentation. And the degree of the edema is depending on how deep it is in your thumb. If it's halfway up your thumb, that's a grade 2. If it's at the top of your thumb or more, that's a grade 4, and you can kind of grade in between them. That's easier than standing there and waiting for the fluid to come back and timing it with your watch. And that you'll want to assess on how far it is up the body. If your patient's been lying in bed for a long time, their edema is not going to be down here with gravity, it's going to be back here with gravity, so you'll want to feel under their sacrum areas or even in the back of their thighs to be checking for edema there. That concludes the cardiovascular part of our exam, and so now we can move down to the abdomen. Again, with this, we're starting with inspection. We're looking at the contour. I've again taking notice of the skin the whole time as I've been watching and looking at each part of his body. I don't see any abnormal contours. This is not bulging out, it's suggesting his liver is large. He doesn't have a bulging flanks that suggest ascites. So traditionally with the belly, we inspect. We auscultate next. If we do other things and push on the belly before we listen, then we might affect the bowel sounds. So after we inspect, we listen first before doing anything else. Bowel sounds are really related to when you last ate. So if I put my stethoscope on his belly and I hear bowel sounds, I don't need to listen everywhere else because it's all the same. It's a closed environment, like a balloon, so it's going to resonate in that chamber. So it's not necessary for me to listen in every quadrant if I've heard the bowel sounds. If I haven't, then I do need to take my time and listen for a minute in each area to try to wait and see if I can find bowel sounds. After assessing for bowel sounds, we move on to percussion. Similar technique as before up in the chest. We expect to have some air in the belly, in the intestines, so that way it should resonate, except here we call it tympanic or tympanetic versus the lungs resonate with resonance. So again, we want to do all 4 quadrants, but we also want to do the epigastric for the stomach bubble, and then even potentially suprapubically as well. So just be systematic and go through each of those areas. Little cold finger, sorry about that. Here we hear the expected stomach bubble here. It's a little more dull over here, which could be simply would be expected likely stool in his colon, which most people would have over there. But whenever you find dullness to percussion, you got to think about what that could be and whether or not you need to consider, being really detailed when you're feeling next to try to feel, is that something unexpected? With soft palpation, it's gentle, it's more superficial. Again, we start off just because if the patient has pain, we don't want to start too deep and just create pain. But this is going to feel the superficial lumps, maybe get an idea, could there be a mass hiding in there? Before you go too deep, if that doesn't bother the patient, then you can go a little further. The technique that I like is using my bottom finger as feelers, and my top is the one that I'm really pushing. So I'm actually pushing on my hand and using my other hand to feel with. The belly should be soft all the way throughout. If you feel like your patient is not able to relax for you, you may need to have them bend their knees up, so that way that'll help their belly relax. I'm going to have them put down just so that way we can show, but that's often something you need to do. If they're overly ticklish, you may have to use their hand kind of over the top, so that way that can help hopefully take away some of that ticklishness issue that you're having if you can't feel their belly. But going on, again, when you're palpating deeply, the abdomen should be soft everywhere. If it's not, then you need to try to figure out what that is that you might be feeling. Is that a mass, something more enlarged? When we get into the abdominal exam later in the year, we'll of course learn how to palpate specifically for the liver and the spleen and the kidneys, etc. But if you are feeling, again, the abdomen, and you feel like you find something firm, then that tells you you need to do a more detailed exam and really try to figure out what that is that you're feeling. So that completes our abdominal exam. So now we can have the patient sit back up again, and we'll finish the core exam with the neuromuscular section. All right, so we have our patient sitting up again, and now we can do a brief neuromuscular exam, which is part of this core exam. Doing strength testing is always patient specific, so he's a young, healthy guy, looks stronger than me, so I know that if I'm going to really test his strength, I'm going to have to push hard enough to really try to find a weakness. A lot of the mistakes I see on rounds sometimes is that everybody treats the patient like a little old lady when they're doing strength testing, and you got to treat them as the patient they are. If he was a big football player, I'd probably have to hang on him to get him to test his strength the way that it might need to be done to find a weakness, because it's about finding a weakness, not just testing resistance. So we're going to do a proximal muscle strength and then a distal muscle strength, both for the upper and lower body. Then we're going to do reflexes, and then we'll do some sensation, and that'll finish kind of our combined neuromuscular exam. I've been paying attention to how he's been moving and following my commands throughout this interaction, so I'm getting that additional information as well. So I'm going to start off with just checking shoulder abduction. I just like to put the patients in the position. It's easier than trying to tell them to do something, which can be a little awkward. So I'm going to have you lift his arms up here, have you hold your arms there, now push up against me, and I'm really going to lean into him until I feel like I've gotten really a good strength test, and you can tell he was very strong there. So he can put his arms down. The next thing I'm going to do is just test his grip strength. So I'm doing something distally, and this 2 fingers, he's going to squeeze my hand, squeeze it, and I'm going to grab on here. Go ahead, squeeze as hard as you can, and I should not be able to pull my fingers out. If I can, either he's sweaty or he's weak, and so that was no trouble there. I would repeat the same thing on the other side with coming over here, putting my fingers in, squeezing, pulling, and I can't pull my fingers out, so obviously he's got good strength there. Now I'm going to just move down to the lower extremity and test, again, a proximal muscle. We're going to do hip flexors. So I'm going to have him lift his thigh up against my hand, and now hold it there. And you can put your hands on the table if you'd like for support. And I'm just going to lean into that while he does that. And you can see he can easily hold most of my weight. And I'm going to compare this side, lift it up here, and I can lean in on that. And he can easily hold that. If that's difficult for your patient, another proximal muscles you can check are the hip abductors. So these gluteals over here, where you can just tell him to pull his knees apart. And I can resist that. And that's another nice proximal muscle you can get. I'm going to move down to his ankles now to get a distal for the lower extremity. I'm going to have him lift his feet up towards the ceiling, just your feet. So lift your big toes and your feet. Good. So he's going to dorsiflex for me, and I'm going to tell him to hold that while I'm going to try to push his ankle down. And I just do that one at a time, and that gets L5. And he can easily resist me while doing that. Now, if I had already had the patient walk and had him walk on his heels and his toes, I would already know that he's got good distal strength, and I wouldn't need to repeat that. But if your patient couldn't do that, then you'll need to test that manually. So that's our strength. We're going to quickly do reflexes. We're going to do his something upper body and something lower body. So it doesn't matter what type of reflex hammer you use. If you get proficient at this one, this is fine. if you use one of these, this is a Babinski. It's essentially a queen square, except it's movable. So I can do this. This is your classic queen square. Either one, it doesn't matter which it is, or if you use a Tromner, those are popular these days. The most important thing is you get good at using it. So I'm going to do an upper body one to start with, and I'm going to try his brachioradialis here. So I'm going to try to hit that tendon, and that should cause him to flex his elbow a little bit, and you see that little flexion. And I'm going to do the other side. His arm should just be relaxed, and I'm just going to get a little bit of flexion, and that shows me that that's intact. You could try the bicep here. The bicep is a little bit more tricky because you got to put your finger and stretch his bicep tendon, have him pronate a little bit, then take your hammer and hit in there. And I can feel his bicep contracting, but you notice you don't see a vigorous jerk, so sometimes that's a little bit hard to differentiate, but as long as I could either see his bicep or feel his bicep contracting, then that would be an appropriate response. But you could see that when I did his brachioradialis, you could actually see the jerk, and that was easy to see. Patellas are always a little easier. This, I always liked, I learned, I had a mentor and he showed me, I slide off the kneecap and I just put that right in there and I can tap it, it works great. You can try to do it like this, but I would again slide it down, you find that groove and then tap it, and you're gonna be on the mark each time, you knowing you're in the right place. But I always learned doing it that way, and it's very successful. Again, doesn't matter what type of hammer you use, just become proficient with it. The last quick part of our neuromuscular exam is just some light touch testing. So you could use, if you wanted to use a Kleenex and touch them with that, you could have them close their eyes if you'd like to, and just ask them to tell us where you're touching them at. Or as a simple screen, you can just say, does this feel the same on both sides of your body? Yes. And working your way down. Yes. And I kind of vary where I'm touching. Yes. And working the way down. Yes. 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 And so he can tell me, I can tell that he understands what I'm asking him to do, and he's able to tell me that it feels the same on both sides. So I've done a quick light touch screen from a neuromuscular standpoint. But again, it's very acceptable to use a piece of cotton or a piece of Kleenex to do the same thing. Or if you wanted to have your patient close your eyes and you touched them and you told them where they were where they were being touched, that's a little more advanced because that takes a little more cognitive and function to do. The last part of the exam would be having your patient walk. This is really best done when they're walking down the hall and they don't even know that you're watching, because everybody walks a little differently when they're being watched. But if not, then you can have them walk quickly, and again have them walk on their heels and toes, which will check some of that strength in the lower extremities. All right, so this has been your core exam. Again, it is a basic head-to-toe exam that hopefully you can use as your base to build upon throughout this year. We've looked at each part of the body: head, eyes, nose, throat, some neck, lymph nodes, cardiovascular, lungs, abdominal, and neuromuscular exam. And again, we've observed his skin on every step of the way here, and if we found something abnormal on any portion of our exam, that would trigger us to do a more detailed exam on that part of the body. And then, of course, from a psychiatric standpoint, our interactions throughout the whole encounter help figure out the speech and his mood and the language content that we were expecting in this part of the core exam.